Good evening, everybody. I'm Aaron Souza. I'm the interim dean here at the College of Human Medicine. I want to welcome you all to what is the first of a series of presentations and lectures related to the COVID-19 pandemic. And I'm really delighted today to have our chair of Epidemiology and Biostats, Dr. Dawn Misra, with us to talk about an epidemiologist perspective on the COVID-19 pandemic. There are still some people joining, and so before I actually introduce Dawn more formally, I just want to thank all of you for joining us tonight. The College of Human Medicine was one of the very first medical schools accredited as a community-based medical school. We have 7 community campuses across the state. About 9 to 10 million people live within a stone's throw of where we educate our students and do our research. We have campuses in the Upper Peninsula, in Traverse City, in Midland, in Flint, in Lansing, in Grand Rapids, and in Southeast Michigan, based out of Southfield. As such, we are one of the nation's larger medical schools. We have research across a large number of disciplines. Our faculty are part of the national conversation on everything from genetics and immunology to epidemiology and public health to biohumanities and bioethics. As such, we have a wonderful group of faculty and a wonderful group of community partners. And one of our goals of this particular series is to link those two groups of wonderful people together. So I want to thank you again for joining us. Dawn Misra, as I said, is going to be talking with us today. Immediately before she came to us to be chair at the Department of Epidemiology and Biostatistics, she was at Wayne State as a professor and director of the Division of Health Equity and the associate chair for research in the Department of Family Medicine and Public Health Sciences. She was before that at Johns Hopkins as an assistant professor of maternal and child health and an associate professor and director of reproductive and women's health and interdepartmental concentration at the University of Michigan's Public Health. She got her PhD from Columbia in epidemiology. And much of her research is on adverse birth outcomes in African American families, including infant mortality, which is actually one of the areas of disproportionate health outcomes and inequity in our country. She expects an increasing number of students will be interested in epidemiology and health disparities because of COVID-19. And we are looking to recruit more students to the discipline and to have a more diverse group of students entering epidemiology and public health. As it turns out, she's a huge fan of August Wilson, and who was an African-American playwright who chronicled the African-American experience. And importantly, even though she was in Baltimore, she started teaching her son to ice skate when he was 2. I want to thank Dawn for her leadership at the college. She has really been an invigorating source of intellectual energy in the college. She has participated in our work toward preparing the campus for COVID-19. She's been a great leader, and I'm thrilled to have her in the college, and I'm thrilled to have her sharing her expertise and experiences with you. I'm sure you will enjoy it as well. And thank you for joining us and being a part of the College of Human Medicine. Dr. Misra?
Thanks for the introduction, Aaron. So I'm going to switch to sharing my screen so you'll be able to see my slides as I go along. And as I'm doing that, I will give a plug. As Dr. Susan mentioned, we do have both, we have graduate degrees in our Department of Epidemiology and Biostatistics in the College of Human Medicine. In fact, we just approved a joint degree for bachelor and master's of science in epidemiology. So that actually will be beginning this year, and we hope to have many more students get interested. We also have a global health minor that's heavily focused on epidemiology and biostatistics that's in the college right now. So I'm going to move my own picture so I can see better. Okay, so my background, I wanted to start with a little bit so you can kind of get some perspective on this talk. I actually was a first generation student in my family to attend college. I grew up in Brighton, Michigan, just outside of Ann Arbor. I went to college in Baltimore and basically stayed on the East Coast for a long time. Came back to Michigan after about good 15 years or so, and started working in the area of the state and also a lot in Detroit. When I was in college, I was studying sociology, and that's when I first learned about the concept of public health and about infant mortality. And I learned about maternal and child health. And a lot of people will focus on maternal and child health as a hallmark of how we treat our populations and how a population is doing in terms of health. And when I was doing that, it first introduced me to the concept of disparities, because disparities are pretty big in maternal and child health. And it's been a major concern that life expectancy really begins with birth. Infant mortality, dying in infancy, has a big effect on life expectancy for the population. And this is where I started thinking a lot more about disparities during college and during this master's degree that I received. So in getting my master's degree, I got very excited when I was taking my first epidemiology course. And that led me on to getting a PhD in epidemiology and also to my focus on health disparities. I was very struck from an early course on the fact that African-American women who were college educated still had a very large increase in risk of having their babies die in the first year of life compared to white women with a college degree. So I started to understand at that very beginning stage that it wasn't just about socioeconomic status. There was something about how Blacks were treated in this country and what the circumstances were in the environment that might be affecting things. So I want to talk a little bit about what epidemiology is and a little bit about health equity, because I want to make sure if there, hopefully maybe there's some younger people out there thinking about school and wanting to know what we're talking about when we say epidemiology. So I've taken the definitions from CDC and broken it up a little bit so people can follow. And probably until the pandemic, I would say most of America had no idea what epidemiology was or who an epidemiologist was. So we are getting a little more popular, but there's still a lot of lack of understanding about what it is. So it is the study, and the studies are what we consider to be scientific, systematic, and data-driven. And that's a really important element in this, and I hope I can demonstrate some of that in the talk. And it's the study of the distribution and determinants. So how is disease spread in the country, or in your state, or in your community? Who gets sick? Who doesn't get sick? Is the rate going up? Is the rate going down? And determinants. What are the causes? What are the risk factors? We pretty much know the determinant of COVID-19. It's being infected with coronavirus. But we don't understand still completely why some people get much sicker than other people. We have some simple answers that hold true somewhat about chronic illnesses, but there's a lot of people who are perfectly healthy who get infected with coronavirus who get very, very sick. And some people are perfectly healthy and get infected and don't get that sick at all. So that determinants, we know the determinant is a virus, but we don't really know in terms of the severity, some of the determinants. Of health-related states and events. So we don't look at just diseases in epidemiology. We also look at health in the population and well-being and trying to predict having good health, not just predicting having disease. And in specified populations. So when you hear an epidemiologist talk about an issue, we're always talking about it in a particular place. So it could be in your neighborhood. We could be describing the conditions at a school, in a city, in a state, in the US, or globally. We do a lot of comparing. So for instance, we might look at the rate of a particular disease or death from a condition in our country versus other countries. And this is a place the United States has not done particularly well. Even if you are a person of privilege in the US and you're healthy and you have insurance, et cetera, you have a shorter life expectancy than in most other developed countries in the world. So we are doing terribly well in the US compared to other countries, and then there's a lot of variation within our country. So what are health disparities? So disparities, this is another CDC definition, and they're pretty much all the same, these definitions about health disparities, but they're considered to be preventable differences. And that's an important concept here, is it is preventable. We don't think health disparities are intrinsic and permanent, and there's no way that they'll ever change. We think everyone has the potential to be healthy and for there not to be differences in risk by race, ethnicity, or by poverty levels. So are there preventable differences in burden of disease, injury, violence, or opportunities to achieve optimal health? And they're experienced by socially disadvantaged populations. So for the most part, that's marked usually by race, ethnicity for minority groups in this country, but it also can be marked by sexual identity, think about like transgender. It can be marked by poverty levels or by education levels. So it's not entirely about a race, ethnicity, although that is where my work focuses. So in my pathway after my PhD, I worked in New York briefly at the Harlem Prevention Center. And this was actually a collaboration between Columbia University and the Harlem Hospital and the community in Harlem. And it was focused on looking at doing a health survey throughout the whole community and making sure that we found everyone in the community to ask some questions. So sort of a little bit, if you think of the census, we really want to make sure no one was missed, and trying to understand more about the health, but also giving the community ownership over that health data. I wrote my very first project when I was there to look at the effects of diesel exhaust on lung function in children. And the reason I did that study was that the community came to us and asked us about, they had concerns about asthma rates in Harlem. And they pointed out that about 90% of the city's bus depots were actually located in Harlem, and a couple of them were across the street from school. So in all of Manhattan, the depots were clustered into Harlem, and in a couple of them being right across the street from schools and be idling in the morning. And so that idea didn't just come to me as a researcher thinking about exposures and outcomes. It came because the community paid attention to what they thought might be a concern, and they shared that with us and worked with us to think of a way to do that study. And that's a lot of what I try to do in my work, is make sure that it's not just from ideas of what I'm reading or thinking about, but it's really community driven. So I describe myself as a perinatal and social epidemiologist. The perinatal part means I mostly study pregnancy and birth outcomes in women's health to some extent. And the social epidemiologist part is really this part about thinking about health equities and how the social environment may impact health. Most of my studies have been looking at the impacts of race and racism on health and well-being in maternal and child health populations. So why step forward in the COVID-19 pandemic? As I've just described, I'm not an infectious disease epidemiologist. We have one of those in the department, and he is making contributions as part of our group, and I'll describe that in a little while. But why would I step forward as someone who doesn't do any research really that's related to this and would be not considered an expert by many people? Well, first of all, I am an epidemiologist, and epidemiologists, even at the most basic level, do learn about infectious diseases, and we learn about quantitative methods. And so all of us actually in our department have quite a bit of capacity, as well as our biostatisticians, for studying and understanding what was going on. But this first screenshot I have for you is from the New York Times headline at the very beginning of our shutdown order, actually in Michigan and at Michigan State University. It's about the coronavirus swamping the local health departments that are already crippled by cuts. And when I started working in public health, when I first finished my PhD in the early 90s, there were already a lot of concerns about cutbacks in health departments. And at the state and local level, we weren't spending enough money. Many of the people who worked in the health department had to handle 3 or 4 different jobs. In fact, we developed a course in infant mortality for people in health departments who were already out working, because sometimes people who worked on infant mortality knew nothing about infant mortality because they were really hired to work on maybe an environmental health problem. So we already knew back in the 90s that there was quite a bit of trouble, and it's just continued on. There were huge budget cuts about 10 years ago during the Great Recession, and those cuts have really never been fully restored. And so our population obviously has continued to increase, and yet we have fewer and fewer people in the state and the local city health departments, county health departments. And many of you may notice that a lot of the work that we talk about being done in this pandemic in terms of tracing contacts of people who tested positive are actually done by your local health department in your county or in your region. So these cuts, I knew from the beginning that there was going to be a problem, because I worked on other projects with the state health departments, sometimes with the local ones, and I already knew how short-staffed they were. So it occurred to me that they were going to need help, and we had a faculty trained in epidemiology and biostatistics that was committed to helping. And so this was one of the first reasons I thought about working with the community and working on COVID. And this is actually a headline from a report from the Trust for the Nation's Health. They actually do a report every year about whether the nation is ready to protect the public's health from diseases, disasters, and bioterrorism, and certainly COVID-19 fits right in here. And they have noted that the public health departments in the country are not ready. Michigan, the state of Michigan operates, is in the middle tier of readiness according to the most recent reports, but it's not in the top tier or the bottom tier, so still work to be done. Also, it's really an unprecedented crisis here in Michigan. As you might have noticed in the early days of the pandemic, for the first couple months, Michigan was one of the epicenters. Probably partly because it was seeded by travelers coming into Detroit. It's from the beginning of the pandemic. But it also quickly spread and then increased heavily in the Detroit area, and there were large disparities by race, ethnicity. And the state of Michigan was one of the earliest health departments to start reporting on race, ethnicity in terms of the pandemic. But I knew from the very beginning of the starting that we were in even more trouble in Michigan compared to some other states. I also, because I went to graduate school in New York, I had lots of friends and colleagues in New York, which was also experiencing some of the same burdens. This is just a quick snapshot. This comes from Bridge, Michigan, the journalism source of the latest data. And this actually just came from a couple days ago. It's 10 a.m. August 30th. And these are the total cases we've seen since the beginning of pandemic in Michigan. And you can see how much of the bottom part of the Lower Peninsula has very large numbers of cases. And we passed 100,000 number of cases, and we're almost at 6,500 in terms of total deaths. So just we could see already that there were definitely difficulties in the state. These are the daily cases since March 25th, and you can see that the peak was around April 14th or so, and we did drop down, and this is all this, the closures were occurring, and as we open back up, you can see this uptick going on, and we're now averaging, somewhere in the 700 cases per day range, which has become increasingly concerning. This is the health equity slide, really. It is the rate of Black and Latino coronavirus cases compared with white cases. So what this is actually showing you is how many times higher the rate is for these two groups. And so back in March, when the pandemic just began and we just started testing for cases, you can see they're about close to 1, right? They're not much higher than whites. But it climbed very rapidly, and it stayed up high during the entire pandemic so far here. This is in the US, not just in Michigan. You can see the rates for Latinos are even a little higher than that for Blacks right now, but they're basically been hovering around almost 3 times the number of cases for whites. The disparity also isn't just in cities. And so there was an article about 2 months ago, a little bit after the 4th of July, New York Times did on disparities in the suburbs. And I just pulled this out because they happen to mention Michigan and Kent County and some of the areas near Michigan State. So in Kent County, including Grand Rapids and its suburbs, Black and Latino residents were accounting for 63% of the cases of COVID-19, but they made up just 20% of the county's population. And at the time, public health officials and elected leaders said there was no really clear reason why this was occurring. Now, some people acted very surprised when the disparities started being reported in the pandemic. For those of us, though, who study health equities and health disparities, this was not a surprise. This has been seen basically for every major health condition we've ever worked with. It looks like the disparity might be even greater for this, and that has to do with the fact that it's a contagious disease possibly, and some of the crowding conditions for housing, but also many of people in these two groups worked in essential industries. So while faculty, for instance, at the university may have been staying and working from home, people who worked in grocery stores, who worked in some of the essential industries within medicine, as healthcare aides in nursing homes, various places were all working. So they didn't have the privilege of staying home. So we think that's part of the difference in rates. Native Americans, we haven't talked a lot about it in Michigan, but the Navajo Nation, which is more in the Southwest, has had the 3rd highest per capita rate of COVID in the country after New Jersey and New York. So this is also particularly a group that's at high risk in terms of having health disparities, and COVID-19 is continuing to be a problem for that group. So My final sort of reason for really stepping forward and getting involved in some of these activities was really a desire to engage in efforts to address health disparities now. In a lot of the work I do, we take a longer term view. I've been doing work for about 20 years on infant mortality. We've made some progress, but we don't expect things to turn around tomorrow. We're not sure what we can do right now to change things. With the pandemic, we started thinking that some of these disparities we were seeing in cases, also in death rates, that perhaps we could figure something out right now and try to do something about it. And we felt like it was urgent to do that. And so I reached out to folks at the health department to ask what our department could do, what could I do, what could other faculty do in terms of addressing the pandemic in the state of Michigan. There are really 4 things that our department and I have been doing around this topic. And I'm going to go through each of them one at a time, but spend most of the time talking about the mortality review that we are just launching in the state. So the first thing that was up was when I contacted the health department. I said, you know, what can we do? We've got people ready to help you. They said, we do have something big for you to do, but it's going to take a couple days, but we'll get back to you. And what we did is we helped staff the provider hotline in the state. So myself and a couple of our faculty did many shifts over a couple of months. This was a phone hotline that you could call to the state of Michigan for physicians or nurses to ask for approval of getting their patient tested for COVID at the state lab. At that time, there were very few hospital systems that set up testing. And so most of the testing that happened in the state of Michigan was actually happening through the health department laboratories. And as part of that system, information needed to be collected, including things on race, ethnicity, but also information so that the patient could be followed by a caseworker from their local health department. And there could be approval. And the guidelines for who could get tested have changed quite a bit over the course of the pandemic. But in the early period, it was pretty restrictive because we didn't have nearly enough tests to be done. So we were only testing certain groups, even though it didn't mean the other people weren't at risk. It just meant we didn't have enough tests to be doing that. So a bunch of us did do some of that, and I would have to say it was also helpful for coping with my own anxiety because it gave us something to do right now. I think many of us in the state, and even now, continue to feel pretty helpless about this. We're not going to be going into a hospital and saving someone immediately, but we know that there's a lot of work that goes into trying to help the population. So this is one of the activities we took part in. The second thing that we got involved in, and this is I'm going to give a little lengthier discussion of, is a COVID-19 mortality review. So there are models of doing mortality reviews for maternal and infant mortality. I had experiences both with the infant mortality reviews and with the maternal mortality reviews actually in the state of Michigan. Ken Rosenman, who's the co-PI in this project, has done work with the state health department around asthma death reviews and sudden death from cardiac conditions. And so the health department reached out to both of us to ask if we would consider developing something to look at COVID-19 mortality. And it's a very different kind of process from what it has the same kind of structure for what we've done for maternal and infant mortality. But obviously, as I mentioned before, it's a much more acute problem. A lot of the things we do with maternal mortality, these other projects have been thinking about longer term recommendations, hoping for change in the longer term. But we're hoping that this can actually have effects sooner. That if we can do this mortality review well, and I'll talk about the components of it in a minute, we might be able to get recommendations that could be implemented now before the next wave and reduce COVID deaths and reduce disparities. So the basic process is that we start with identifying deaths from state records. There were, as I showed in the earlier slide, there's been almost 7,000 deaths now, right? So we can't study all of them. When I explain the process to you, you'll see why it's a pretty in-depth process. It's not like counting the cases. So we decided to sample 100 of the deaths, to draw a sample of 100 deaths that occurred to people in Michigan from COVID-19. We wanted to make sure that we considered both people who died before the peak of the pandemic hit in Michigan, so that's all through March and early April, the peak, which happened around the middle of April, and after the peak. And our reason for doing this is we thought some different factors might have been at play in people who died early in the pandemic versus later. And we also want to make sure we covered all of Michigan. So we had some what we call stratification, where we chose cases of deaths that happened in different sets of counties, made sure that we oversampled slightly in Detroit, because as many of you know, Detroit really bore the brunt of the deaths and the cases. But we want to make sure we had it all over the state, because some things may have been issues maybe in the Upper Peninsula or in the western part of Michigan in terms of either the healthcare system or in terms of patients' ability to access care that differ between those areas of the state. So we want to make sure that we're really covering the state. So the first step in this process, and one we've just begun literally in the last week, is to retrieve the death certificates for these cases, identify who their next of kin is, and identify the last hospitalization before they died. Now, some people did die out of hospital, but sometimes they had interactions with the healthcare system before that we're going to try to find out about. A healthcare provider, a physician with some specialty experience, is going to review the quality and appropriateness of healthcare from those records. They're going to look at the hospitalizations of those patients who passed away, if they were in long-term care facilities, what the conditions were, had they been in emergency departments, what happened to them in the ER, what happened at urgent care, what happened in an outpatient visit. So typically we'll start with a hospitalization that led to the death, but we work our way backwards to make sure that we can look at all of the care that case received. We're also going to do next of kin interviews, and this is done in some of the other mortality review programs, and we think this will be particularly important in Michigan to consider in terms of disparities. We're trying to get really a narrative story of what happened to the person who died from the time that they first started getting sick until they died. We want to identify all the healthcare interactions that happened in that period before death. Want to gather experiences of discrimination that they may have experienced in obtaining COVID-19 testing and care, and look at also chronic and other conditions that could have contributed to risk. Now remember, this is being done with your next of kin. And it's the person is identified on the death certificate. It might take us a little work to find the best next of kin. They may not know the answers to all of these questions, but we think that they may know some of the answers at least. And our plan is to record these interviews and to really look at, with what we call qualitative research, to look for themes that are present. And we might be seeing certain themes that happened in Detroit that didn't happen in other parts of the state, some things that may have happened to one particular minority subgroup than other groups. Men versus women, we do know there are differences, but in the death rate by gender. So this is not a comparison study. It's not like we're going to go look at people who died and compare them to people who got COVID and didn't die. That's a very different kind of study. This is meant to be an in-depth study to really look at what we think are systems factors that could be changed that may lead to prevention. And we do it by this in-depth sort of deep dive into the cases. After the information's been gathered from the medical records being reviewed by physicians, from our interviewers interviewing the next of kin, we're going to take that material that's been summarized and we're going to present that to a case review team. And these will probably be about 10 of these will be done. They're typically done in a community, so we might do them geographically, where they look at all the information that's been gathered and discuss the case. And in some things like maternal mortality, we use a preventability matrix and we think about how preventable the case would have been and in various levels of what could have happened. We include community members there as well as professionals. So it's not just a bunch of physicians or epidemiologists or government workers looking at these cases. There's people from the community that look at the case as well. There are confidentiality agreements. We don't use names in any of this, but we talk about what happened with those patients or those deaths. Then we also plan to have a community action team that we hope can take some of the recommendations that come out of the case review teams and really affect change. And so that will include community in terms of community groups. They'll also include local and state government, and maybe that we make changes to our Medicaid policies. We might make changes to other insurance plan decisions, and healthcare system leaders. As you all know, many of our major healthcare systems were heavily involved in caring for patients during the pandemic. If we identify issues in terms of patients' access to care or particular care issues that happen in hospitals, the best way to get those things to change is obviously bring the people who are involved in those actions to the table. And so these things have happened in past work in infant mortality, maternal mortality, and the asthma and cardiac cases I mentioned my colleague has worked on. So we do know that these systems actually can help. It's just we're trying to do it a little more quickly than we usually do. So we're hoping that we can be productive a little more rapidly than usual. The other area in which I've been involved in the pandemic in terms of thinking about its impact is in my own study. I'm a co-investigator in a study called BIB. It's a study of pregnant women, but many of them have delivered since the start of the study. So also we studied postpartum Black women. It's only Black women in our study. And we added a survey shortly after the pandemic began to try to study how COVID might be affecting social and psychosocial stressors. So as everyone might have experienced by now, the pandemic is causing a lot of stress for people, both in terms of their financial situation. They may have gotten laid off from work. They may not have been able to go out. They may have had increased stress from their relationships. Maybe in terms of people have been concerned about intimate partner violence, maybe increasing because everyone was staying at home. So we asked questions about that. And it may be that the pandemic, even when people aren't infected, had a very adverse effect on people's lives because of the other damage that it did. So this included, we did surveys, but we also included qualitative telephone interviews with the women about the impact of COVID. And our early results, interestingly, and this is in a group of women who are under a great deal of stress. These are all Black women in the Detroit metro area and Columbus, Ohio area. We did not see an increase in depressive symptoms or stress in this group, and it may have been because they were highly stressed to begin with, but we did show we are seeing negative effects on income and food security and some of the economic stressors for this group. It's a very small sample to start with. And finally, we're doing some stuff, I guess you could say, in our own backyard at home. So the university, in efforts to reopen and plan for a change for this year, created a lot of working groups across campus. And as epidemiologists and biostatisticians, we felt we had expertise to offer those groups. So our department, many of the faculty in our department have been represented on various working groups. We also have an ad hoc group in our department led by Claudia Holzman and Gustavo de los Campos in our department, who are kind of bringing all the information together once a week. So once a week we meet and we bring information from all the different groups on campus and try to think about what are some of the key issues that we can contribute to. So we've been very involved in thinking about the surveillance testing program that the university wants to launch, and thinking about looking at behaviors, thinking about what positive tests mean, what negative tests mean, and trying to help people better understand the meaning of COVID-19 testing. And generally trying to be a source of what we consider expertise in key factors around the pandemic. Obviously, there's many areas that contribute to the expertise for the university: communications folks, people who study health behaviors, the laboratory groups. You're going to, I think, hear a speaker in the next couple of weeks talking about the laboratory testing for saliva testing. So it's all part of a really big team effort to work on trying to figure out how we can safely reopen and how we can keep the community safe. And so even though we're going virtual this semester, the university is very interested in trying to keep the community safe and our students safe, even if they are not on the campus per se. So this work hasn't stopped just because of the virtual. So we're hoping to have systems put in place and improve things so that people can be safe. And I just wanted to end with a couple nice posters. There's a website called amplifier.org that does a lot of free art. You can download them for free. You can also buy posters of them if you want. I thought this was a good one of "We Got This" and "Keep Your Distance, Give Your Kindness." We got one on "Together, Distance is Resistance. Protect people, stop the spread." This is "Protect Our Elders." And this one is "Protect Migrant and Refugee Detainees from COVID-19. So I'm going to stop here, and I guess I'll leave the sharing up. I think I can still see some of the chat questions. Should I leave the screen share up, Nikki?
Yeah, that'd be okay. I would read our first question to kind of kick off everything, and thank you. That was a wonderful presentation. But someone is asking, their question is covered just, okay, my question is it covered just like influenza A? People are saying that, why do we have to wear masks because of COVID? It's the same as influenza A. What is your intake on that?
Well, it's proven to be much more contagious and much more transmissible than influenza A, the first part of this. The second part of this is interesting. I finally got my hair cut after 4 months of the pandemic. And when I was talking to the person who cuts my hair, she was saying that she's going to wear a mask every flu season from now on, now that she's wearing it for COVID. And she thinks she's going to be that she'll get the flu less because a lot of people will still go and get their hair cutting when they're sick. And so it does help reduce transmission from influenza, but culturally we have not, other countries do this, but we have not chosen to do that with influenza. But it certainly can help reduce transmission of influenza as well. But yes, this is much more contagious as best we can tell.
Great. And a second question that we had submitted in advance is, I hear people think the numbers are skewed in terms of death rate, attributing too many deaths to COVID when they are predisposed to dying due to an underlying condition. Do you believe this to be true?
No. Actually, if anything, many of us think in epidemiology and biostatistics that the numbers are actually, we haven't actually counted all of the deaths. What's interesting is there are past examples of this from different influenza epidemics. You don't have to go all the way back to 1918. You can look at other years where we had surges of flu. And you can see if you compare the rates of death or the numbers of deaths from the year prior, same season and year prior, you can see how many more deaths we actually had this year than we did in previous years during March, April, and May. So even if maybe a few things might have been miscounted, maybe somebody really did have a heart attack and had nothing to do with their positive COVID rate, the fact that we had so many excess deaths suggests actually, and if you look at that excess isn't even fully counted in the COVID death rate. So I think that these things often do take a time. I think our death rate will go up actually, in fact, when we have a little more distance from it and we've really had time to model what the numbers of deaths should have been had there been no, like in a normal year. So I don't subscribe to that thinking at all.
Okay. Another person says, I have been reading and listening to specialists who have found that the amount of toxins that infants are born with has increased dramatically, and that has been found to affect infant health and mortality. I have also learned that babies born in this time have been found to have up to 600 toxins in their body. These toxins have been passed down to infants from their parents.
So I can't speak too much to that. It would require probably a whole nother conversation and depends on what you want to call toxins and what we're talking about. So yeah, I think we'll defer to answering that.
I'm concerned about the numbers being skewed due to those people who have taken multiple tests, but are counted as individual cases. Can you speak to the testing numbers?
There was some initial concern that there was some double counting and things, but the way that the actual system is when the test results are in the health department's tracking systems, there is one person, one test result. Someone can get tested later sometimes to make, because they could have been exposed again. And if you're a case, you're a case. We don't double count cases if you get tested positive a couple times, like say you get retested sometime during the course of the disease. We don't count those again as new cases because they're tied to an individual. The other thing is, to be honest, with the way the testing availability was, at least for the first 3 months or so, we rarely could test anybody a second time during the course of their illness. Some of the hospitals wanted to be able to do that, and we almost never had enough tests available to do that.
Perfect. Another person is saying, how likely would it be to get infected from a physical object or surface? Also,
go ahead.
Sorry, there's a little more. Also, talk about viral load and if this is a factor in infection, symptoms, and spread. Kind of scared even just walking into places to pick up food, hoping to get in and out fast, hoping low viral load would help.
Yeah, so I think the surfaces thing, we definitely, this is an area that kind of, it's important to think about what science really is. I think many people were surprised when guidance changed, right? When we said one thing, then we said something else the next week, and people got scared. That meant we had no idea what was going on. Science is partly doing many studies and then looking for consensus among them. There's no one single study that's going to give you the perfect answer about something. So some of our guidance is, on mask change. Actually, we never really thought they were a bad idea. We just weren't sure that they could be that helpful. So that was really more of we want to make sure there were enough for healthcare providers, and we weren't sure of the degree of helpfulness. So when that, the guidance around objects and, food containers and things like that, early on in the pandemic, there was a lot of focus on, we could find, a cell of COVID on this plastic takeout container. But finding it somewhere and it transmitting to you are not the same thing. So the amount of viral material that was on surfaces generally was not that much after a certain time had passed. Then there also has to be the issue of you have to get it from there into your body somehow. So touching it, not washing your hands, touching your eyes and your mouth would have to occur. And as I mentioned, enough load of the virus. So we pretty much come to the conclusion that we should wash hands or use hand sanitizer all the time, but no one is any longer recommending that you scrub all of your takeout containers or anything that something comes in. And I think we might have Dr. Contag or Dr. Lipton talking in this series, and they can speak a little bit more about it from the laboratory work. But the laboratory recovery of the virus doesn't mean that it's necessarily going to transmit to you. So the second part is, being worried about when you're going into a store or somewhere to go. The CDC says 15 minutes of close exposure is what they consider a close contact. And generally people who are going into grocery stores and these things are not around somebody closely for that long during the period of time. So one of the things I think about is how can you reduce your risk? You can't eliminate all risk, but how can you reduce it? So if I'm going to go get my hair cut, maybe I won't go to other stores or do anything else this week because that's going to be my big risky exposure for the week, even wearing a mask, them wearing a mask. If I'm going to go takeout, I'm going to make sure that I call and that it's ready for me before I go into the store. Or I'm going to do curbside. Same thing with the hair salon. I'm not going to, I actually stopped, it hasn't showed up yet, but I stopped coloring my hair, I think, because the salon I went to, even though they said they would not have a waiting room and things, in reality, they had you in the chair and had you waiting, and I left. And I waited in the car, and then I came back in, and then I went out in the car again because I didn't want to increase my amount of time being exposed to possible risk. So some of it is making your own decisions, even when they're uncomfortable sometimes, about the amount of time you want to spend in an establishment. And if the food's not ready, then you're going to go back outside. In fact, I even did that in an MRI waiting room a couple weeks ago. They had every other seat taped off, but I looked at it and thought there were just too many people in here. And I said, you know what, I'm going to go out in the hallway. Call me when you're ready for me. So I think we can all take some personal actions to try to reduce risk. And we're not going to be able to entirely eliminate it, but pretty much if you're not spending a lot of time close to people and you're wearing a mask, I think you're doing pretty well.
Great, thank you. That was very informative. Someone is asking, who's the source for the art that you shared?
Oh, so it's amplifier.org. They've got lots of great art on the pandemic and on other social justice issues. And as I said, you can download it for free, but you can also order posters from them. They have a We the People series. It's actually up in my office, where I haven't seen in 6 months. It's there, but yeah, a lot of it is trying to message some of these, I think, important messages.
Perfect. And now our next couple questions are in regards to the vaccine, and this person is apologizing that they arrived a little late, so if this was covered, but what do you think about the FDA giving a vaccine in an emergency authorization before phase 3 trials are complete?
I haven't seen enough of the data to make me comfortable about that. Doesn't mean it's not out there, but generally, yes, we wait for phase 3 trials to be complete. And, there are a lot of things in medicine and health that we have found don't work the way we think they do until we get to the very end. And so, yeah, a lot of therapies we've used when even after phase 3 trials have shown them to be effective, sometimes we find in the long run they're still not that effective in real life. So I think I don't know, I haven't heard that the FDA is doing that. But I'm not entirely sure that I would be signing up for the vaccine if it hasn't reached the phase 3 trials yet.
Okay, what would you say is the vaccine efficacy rate? And do we expect that a person who is successfully vaccinated to still be vulnerable if they're exposed to a high enough viral load in the future?
So we don't really know what the vaccine efficacy rates are going to be for the COVID vaccines, and we're still in such early stages of it. And some people who get the flu vaccine, and everyone should be getting, so I plug for the flu vaccine, everyone should be getting it as soon as they can this year. We do have Michigan's one of the worst states, and actually that was part of our ranking for this preparedness for a health disaster. We have one of the lowest rates of flu vaccine uptake in the country. We have about maybe half the population gets a flu vaccine. And so part of what happens is if nobody gets the vaccine, then things don't work so well either. But sometimes the vaccines vary. The flu vaccine has varied in its efficacy from year to year. I think last year's vaccine was considered to be not that efficacious. However, people who got sick got much less sick. Their cases were milder. They may have transmitted it less because they're having lower viral loads. So even in the case of something that's not as efficacious as we would like, it still can be quite beneficial. So I think I really don't know enough yet about what we think the rates are going to be. But in my opinion, if we get phase 3 trials and it's efficacious enough for approval, then I would be getting it and hoping that, maybe they'll keep working on one that gets even more efficacious. And the more people, of course, that get the vaccine, the concept we talk about, herd immunity, can be from getting the disease or from getting the vaccine. If we have a lot of people get the vaccine, if we move those rates from 50% for flu vaccine to 95%, even if the vaccine's not that effective, everybody has a good amount of protection. So I'd be looking to that too.
Great. What advice would you give to educators in the realm of higher education to deal with behavior and its impact on the spread of infection?
I'm not sure I entirely understand the question. They're asking, thinking whether faculty should do something about behavior of students in their classes.
Yeah, it looks like any advice that you would have to give them to help with dealing with the behaviors that this population group has and its impact on the spread of infection.
Yeah, so I spent some time today talking to some experts at Michigan State about behaviors and norms and attitudes. And, there is a overwhelming in adolescents and what we call emerging adults and people in their 20s, a feeling of invulnerability. So that has to be, that's coupled with how much they feel something is a threat, whether or not they think the steps they can take would be efficacious, and then whether they think they can actually undertake the steps. So all those things interact in terms of young people in a classroom setting in college deciding to take these steps. It's not clear entirely yet, I think, what messaging we can do to improve that and how faculty can improve it, but I think we pretty well know what won't work. And there's pretty good evidence that anything to do with shaming generally is not effective and is counterproductive in terms of addressing these behaviors. And I would also say that when something seems risky, some people may remember that there used to be campaigns that were anti-smoking campaigns that focused on, oh, you're gonna die of lung cancer, this horrible thing's gonna happen to you. And it turned out that those were counterproductive with adolescents, and they tended to increase smoking rates, not decrease them, because adolescents like to take risks, and so they thought of it as being more of an adult and sort of found it appealing to do this, right? So then the smoking campaign shifted to more things about vanity and how it might make you look bad and you'd have bad breath and things, and those tended to be more effective in terms of it. But what was ultimately effective was making cigarettes too expensive to buy, and that's actually had much bigger impacts than almost anything else. So we can't really make something about COVID probably too expensive to have. But I think the mask wearing, trying to teach people the reason why, what's the evidence behind it. I think, young people do respond to rational thinking, and they do want things, and they also respond, I think, to altruism. They do care about their fellow human beings. They want things to be better. They just may have some difficulty sometimes with decision making for a number of reasons that most the scientists who study them know about, with the brain not maturing yet about some of the decisions they make. So I'm not really sure in a classroom how much you can do other than try to educate and try to explain some of the science behind the steps we're taking.
Perfect. What's your opinion on gyms reopening and the risk of infection?
Well, I don't know. We'll see what the governor's going to say next week. There isn't really great data yet from other cities, from other countries about what might happen with this. I mean, some of them have opened in other states, but they really haven't been that well attended. There was a study circulating for a while that was in Scandinavia, and everyone was very excited about it because they showed that, they didn't seem to be any increases after 2 weeks. But that's like after 2 weeks. And so it was a pretty short study. And so we didn't think the other problem with the study in terms of generalizing it to Michigan or the US was that it was in a Scandinavian country with extremely low community transmission rates. So as long as our community transmission rates remain high, that means people from the community who go in those gyms may be asymptomatic, they may be what we call pre-symptomatic and capable of spreading it. Exerting yourself, when we talk about the viral load issue, if you're breathing hard, you're going to be expressing a lot more viral load if you have any than someone who's just talking quietly or not really speaking, even who's close to you. So I know that there's an economic issue, and I don't think at this point, I think our community transmission is kind of in this iffy place right now. And so the gyms up north have opened. There don't seem to have been increasing problems from them yet, but they are keeping capacity down. And to be perfectly honest, on a personal note, I wouldn't do it because I feel like that close proximity is really difficult to be in close proximity as much as I try distancing in a gym while breathing hard and in an enclosed space. I would just find that a very difficult risk to take. So I'm keeping my exercising to at home and outside for the probably until there's a vaccine.
Agreed. I think we already covered this one, but do you have anything else to add on herd immunity, and is it possible with this virus, and why or why not?
Well, there's going to be two problems with herd immunity until we get a vaccine. One is that the number of deaths is really unacceptable to reach herd immunity, right? So we've already had almost 200,000 deaths in the United States. And if you look at the prevalence studies, the antibody studies that were done in New York to try to see how many people might have some immunity or antibody resistance, it's actually not that high despite being the center of the pandemic. Which suggests that you can have a lot of deaths and still not have much immunity. And then there have been these 3 recent cases, one I think in Europe, one somewhere else, and one here in the United States, that did show reinfection for someone who'd had a case. I believe in both of those cases, they were milder cases, but they definitely were people who had COVID, tested positive, and became reinfected some months later. So there's a lot of concern right now whether natural infections, so not vaccine acquired antibodies, really is going that those antibodies are going to persist long enough to protect you. So when we talk about herd immunity, we're generally talking about infections where your antibody levels go up quite a bit and they persist and stay so that you really are protected. So I think that's still an open question whether getting infected is really going to help us reach herd immunity. But certainly with the fatality rate right now, I can't advocate for that as a responsible way of reaching herd immunity.
Perfect. This one's a little bit different, but in serving our students, this person is saying, I'm currently an undergraduate statistic major at MSU and hoping to get my master's in biostatistics. I'm curious what specific roles did the biostatisticians that you worked with have, and what guidance did they give in helping with investigating the deaths of COVID?
Yeah, so they've been doing a great job for us. They've been involved in a couple different ways. One of them is co-leading our working group in the department. And what he's been doing is helping with doing really modeling. So basically, we've known about rates that are occurring in the community and really taking those and saying, well, what would happen if? What's going to happen in the next stages? What are the different conditions under which we might have this rate or that rate? It's really taking the information and making models. And you've seen a lot about models in the news about this. And so really using basic methods of modeling. The other place that they're giving input is around the surveillance program, about how we should sample in the surveillance program and how we need to actually do surveillance testing if we're really going to learn more about what's going on campus. So surveillance testing, for those of you who don't know, is actually testing people not because they have symptoms or because they've had close contact, but testing just not everybody, but testing a sample of everybody without symptoms on campus. So that we can better understand how much is the virus out there in the community and we're maybe missing it because of this concern with people who don't have symptoms or are pre-symptomatic. The other way in which one of our biostatisticians is helping out, One of the community hospitals came to me early on. I'd worked with them through some of my research to ask for help in looking at their hospital data. They wanted to look at what was predicting what their mortality rates were looking like. They had about 1,200 COVID cases that had been admitted in March, April, and May. And they wanted to start looking at that to understand what were the predictors of mortality in their own hospital system. So I helped them with getting a database set up and in planning the questions, but at a certain point I turned it over to one of our senior biostatisticians, Joseph Gardner, because I figured that he actually, at the point we'd gotten to now, we had data, and now we need to think about more advanced ways of testing the hypotheses, that he would work with them to do that. And there's a lot that goes into thinking about how to look at hospital data. It's a little different than looking at community population level data. And we encourage you, yes, to apply for the MS.
Can you talk a bit about air travel and how to reduce risks associated with it?
Yeah, so I initially was very worried about air travel, and I've got a son who's in college in Oregon. So for him coming home, I was like, I want him home, but then I didn't want him on the plane. I was trying to figure out what we're gonna do about this. And then they started to come out with some studies, some of it through engineering, really, examinations of how airplanes work. And there were a couple early cases where there were infected passengers on the flights and people did not get sick, so trying to figure that out. The plane itself turns out to probably be the least of our problems. It's really the airport terminal, the getting to the airport, the things that might end up with you being around other people in close settings. I think having the separateness of these extra space on the plane, not loading the plane up, just like we talked about not loading up, waiting rooms and other places. It definitely increases safety. Wearing masks clearly does. But planes turn out that they actually change their air. They don't recirculate their air very much on planes. So in that sense, they might be a better airborne system than in terms of protecting us than other things are. So I think, if the carriers continue, some of them are no longer limiting the number of people on the plane. I guess we will see in a natural experiment fashion if that ends up leading to increases in cases. So I do think having less people on the plane is definitely one way to benefit it, and trying to get on the plane. They're actually loading the planes, I think, a little more carefully now too, of front to back, and not letting people wait that long in the places to get on the plane. And continuing to practice social distancing as much as you can in the airport and the security line and places like that, hand washing, because you're touching a lot of things as you're trying to get through an airport and get onto a plane.
Great. What would you say is the risk of exposure for particles released prior to your presence in a space? So say you have a one-on-one mass encounter and you're 6 feet apart. Is it okay to take a mask off in that space after?
Oh, I don't know. I haven't thought that much about that. I probably don't know enough about the aerosol things of doing it. It would seem after a certain amount of time, depending on airflow and stuff, it wouldn't be an issue. But there have been some of these studies done, really well done engineering work that suggests that the particles stay suspended for quite a while. They're even when we're farther apart than we think. And again, though, those are laboratory studies to some extent, and we're not entirely sure what the level of transmission is from those kinds of encounters. We know that they can detect virus in these places, but we don't entirely know for sure that that's going to lead to cases. There were some very concerning real-world scenarios early on in the pandemic. I think they were from China, from a restaurant where the air conditioner airflow definitely showed that people got infected who were far from the other people, and it was because of the flow of air from an infected table to another table. So there are some concerns about those things, but we've done much more on the engineering than we have on the real-world application of assessing those.
Great. And this one is definitely one I don't really understand, but speaking as an epidemiologist, what is your perspective on long haulers? Given the widely varied symptomatology, how would the long haulers phenomenon be studied in a way that would educate whether this is really COVID effect as opposed to something else?
I didn't get that first word. What, long hauler?
Long haulers? That's not one that I'm familiar with either. It's LONG-haulers. Is that a phrase?
I have no idea.
Okay. Maybe we will have to skip that.
Yeah.
And then what would you say is the biggest reason the U.S. is lagging behind other countries in terms of infection rate, death rate, etc.?
Well, I think we had a lot of lack of will to do all the things we need to do. We were slow. We've been slow to really enforce things, to have, I mean, I think our governor has done an outstanding job of putting forth guidance about this, and the level of testing. I mean, we don't have a national testing strategy. We barely have a state level testing strategy. We've been so behind on both protective equipment, supplies, and there's a new report now that nurses in a lot of places throughout the country still don't have enough protective equipment. They're having to reuse things. So I think we didn't have a lot of the tools we needed to fight this, both the protective equipment for our health providers and now the masks even were pretty difficult. I mean, I think of how difficult it was for us to get masks in my household, even though my husband was on top of it from day one. And for families that, don't have a lot of resources or ability, it probably took a while. I think they're more available now, but it's not that easy. And the testing is quite variable about availability. And so I think the level, and we've never sort of sat down and figured out a strategy of who should we test, how much should we be testing, and had a really guidance from federal level about what we need to do about that. So I think until we have that, we're going to keep struggling. I think countries that did better had supplies for protective equipment. They had high numbers of tests. They tested a high proportion of their population. And they also get rapid return of test results. So if you lag in getting the test results back, it's almost useless in terms of COVID control. It's helpful for the patient and for the provider to know, but in terms of trying to make sure that people are quarantined who've been around that contact, if you're taking, more than 2 or 3 days, you're really losing that battle quite a bit. So some of the very basic things we do of testing, getting the results back, getting contact tracing going, we are woefully unprepared in the number of people to do contact tracing. So we're basically understaffed and unplanned, I guess are the 2 words I've used for why we're not doing as well.
Great, and it is 7:30 and we have about 2 more questions, so we're going to go a couple minutes over, but I think these 2 questions would be good. So how do you think the field of epidemiology will change as a result of COVID? Do you see any lasting changes to public health and or systemic changes that will be with us post-COVID?
Well, in terms of the research, I think that there's going to be the immediate control of the pandemic, but from what people are seeing, even if you don't die from COVID, there are a lot of survivors with pretty substantial sequelae. And so I think in our field, there will be more studies of those patients and the effects on their health long term. But in terms of public health, and this is one of the saddest things from the Nation's Trust report, the Nation's Health Trust, if you go to look at their website, we've had these infusions during Ebola, during Zika. We have a public health threat. We put a big infusion of cash into it. And there are little blips, but then everything kind of goes back to normal. And so we don't make sure that we have enough health department staff, a ratio that's high enough for them really to really tackle these crises. You can't just instantly train a lot of people and instantly hire people. And in fact, the money wasn't enough to really do that either. But what we end up doing is kind of responding to each emergency like a Band-Aid. And so I'm really hoping that there will be change with this, that we'll see sort of what the risk was of not being ready for this. And Zika fizzled out a little bit quickly in the North American area as did Ebola, but Ebola operates very differently than COVID, killing people sort of almost before they can transmit it. So it did not reach the level of contagion that COVID did. So I'm not sure. I'm really hoping that our government and public health will find a way to be more prepared in the future and keep this level and increase the level of preparation, but I'm not confident about it yet.
Great, and our final question is a little bit long, but someone is saying that they became very ill in the past from just having a flu vaccine, and they're very hesitant then to get a vaccine for COVID. And they've read about a study showing that memory T cells that people have from recovering from the common cold virus because being coronavirus, they have very similar protein, and these helped people to recover from COVID-19. I read that it's actually a better mechanism than getting a vaccine, which stimulates beta cell production. Have you heard about this?
I've heard about it a little bit. I don't think I'm totally qualified to comment on all the science. I do know that study came out, but it's been one of the very first studies. So I'd say, again, we think about science. I'm not sure that we've had enough replication of those results about the memory cells. We do have a long record of showing that vaccines are very effective ways of producing immunity. So while that might be a nice benefit while we don't have the vaccine, I don't see that as being a solution to the problem, because we have lots of people who were vaccinated in childhood and got all those vaccines, and they're still getting COVID. They might not get it as often as someone who never got their childhood vaccines or haven't been vaccinated for the flu recently. But it's not like it's stopping all of the COVID transmission. So I think it might be a tiny thing that might help some, but it's not going to be enough to rely upon. And, you know, the getting sick from the vaccine, I will say two things about that. One is that sometimes we just get sick. And we tend to associate, oh, it was because I got that vaccine. It may have been that you just were getting sick. And there are some effects, but the effects that we've shown in very few, except in very, very few cases of vaccines are, you know, they're mild, they're a little bit miserable, but they're nothing like having the disease. So that's what I'd say in terms of thinking about whether it's worth it to take the vaccine. The disease is far worse than the vaccine possible mild disease would be. And many of the new vaccines are actually not being used of killed virus or live virus. They're actually some newer methods in terms of vaccine technology. So I think the likelihood of getting ill from the vaccine is going to be different.
Great, thank you. And I think that wraps it up. We did have some questions that were unanswered. So we thank everybody for giving us so many wonderful questions, and Dr. Misra for your fabulous talk. And
well, thanks for being with me. And if you have questions, if you really have a burning question, you want to ask it, I am findable on the web. You can send me an email to the university. It may or may not get past the university filters. I can never tell, but feel free to try to reach out.
Yeah, and if anyone is unable to get through to Dawn or can't find her, then you can certainly message me. You probably have my email from your confirmation, and I can be sure to get it to her. So thank you, everyone, and thank you, Dr. Misra. This was wonderful, and stay tuned for our next one.
Okay, have a good evening. Thank you.